Okay, let's go ahead and get started. Good afternoon and welcome everyone. Thank you so much for attending this training on engaging youth about HIV and substance use, trauma-informed concepts and strategies. For folks who don't know me, my name is Esraya. I'm a research project coordinator with the EDIT program at Northwestern, and we are very excited to have you here as well as Connect for Youth here today. I hope that you all are too. I just want to say thank you in advance for your attention and participation in the training session today. Before we get started, I just have a few housekeeping items. The first one is that this training will be recorded and available to you as well as your colleagues if you'd like to pass it on via a box folder, along with the slides used in today's presentation. They're also linked in the calendar invitation if you'd like to access those with notes so that you can follow along during the presentation. So with that link that's going to be shared with today's recordings are also the slide decks and previous recordings from trainings that we've hosted throughout the last 2 years in that box folder. So we'll go ahead and link that in a follow-up after today's training. During this training, we would hope that folks participate as you would as you were in person. We will have a couple breakout rooms. We just want to make the most of each other's time while we're here today. And then the last thing is, beyond those announcements, we just ask that you keep yourself muted when you're not speaking to minimize background noise during the training. If folks have any questions about accessing the slide deck in the calendar invitation, let me know and I can re-forward it to you. Just feel free to chat me in the Zoom chat. And without further ado, I'll go ahead and pass it off to our facilitators. Thank you so much for being here, everybody.
Thank you, Azariah. Hi, everyone. Thank you for taking the time to participate in our training today. My name is Hamid Dadka. I use he, him pronouns, and I am the coordinator for the Connect for Youth program at Lurie Children's Division of Adolescent and Young Adult Medicine. Our training today will cover a few main components. One will be trauma-informed concepts. So we'll give you a high-level overview of what it means to be trauma-informed in your work. Then we're going to briefly touch on some of the ACE study information to talk a little bit about why we are approaching our work from a trauma-informed perspective. And then we are going to jump into some of the specific strategies that might go along with those trauma-informed principles. And then finally, we're going to follow it up with an overview of the HIV care continuum, along with some discussion about different strategies from the trauma-informed perspective that you can use to encourage any individuals that you support through your work to make progress through that continuum. And we're going to go ahead and any additional questions that we're not able to cover today, I'm happy to reach out to individuals directly after the training if you want to provide your contact information, or I could follow up with some answers to Azraya to share with the group as a whole.
Hamid, do you want to answer the question in the chat about ACEs?
Absolutely. So with the training, and we'll go over this in a little more detail later, there is a study that was completed called the Adverse Childhood Experience Study. And it really illuminated some of the long-term health impact of experiencing a variety of stressful and traumatic experiences as a young person. I'll share a little more in detail about what that means. We have a few slides that highlight what that study was and what it looked at, but that's what we're talking about with regard to this training. All right, we're going to go ahead and get started here. If you're still finishing up the survey, no problem. If you do feel like you need a little bit extra time, feel free to throw that in the chat and I'll slow down. But just to give you an overview of what the Connect for Youth program is, it is a new project that is in partnership with Lurie Children's Hospital and Haymarket Center. That's a SAMHSA-funded program that offers integrated substance use and HIV screening, testing, and linkage to care for youth of color in Chicago, age 16 through 25. We'll talk a little bit more about why those two topics are related and why we are approaching this work with this particular population as we go through the training. But our project as a whole has a few different big components. The main one is to actually enroll young people in that target population, so youth of color age 16 through 25, in a service that provides some risk screening around substance use and HIV, It provides some education about the intersection of HIV and substance use risk. And then it provides some testing for HIV and possibility of connection to follow-up services through our partners at Haymarket, who provide the navigation services that are critical to this project. For any young people who screen at risk for substance use or HIV, they're able to connect with up to 6 months of follow-along navigation services to access various prevention and treatment resources for either substance use and or HIV. We also have a prevention messaging component, primarily via social media, to get some information out there to this population about why it's important to access screening and testing and treatment services. And then what we have right here is a clinician training that targets particularly providers who might interact with young people in our target population around HIV or substance use needs, with the goal of equipping those providers with strategies that are trauma-informed to make those services more comfortable, accessible, and effective for this population. So just some course objectives to give you some information on what we'll be covering today. By the end of this course, you will learn some concepts and benefits of trauma-informed care. You will understand how trauma, HIV risk, and substance use risk intersect. You'll be able to define the stages of the HIV care continuum. You'll explore some local care statistics and identify some barriers by continuum stage. And you'll have a few strategies and ideas on ways that you can engage youth that you work with or that you serve more effectively around any substance use or HIV needs that they may have. As we're going through this training, just kind of keep in mind some things that you might do in your daily work that might bring you in contact with our target population or prompt you to have to offer some support or guidance around substance use or HIV needs. And in particular, some thoughts that you may have about how trauma, either clinical trauma or traumatic experiences might affect that young person's ability to engage with you specifically through whatever your work role might be. So just some definitions. We're going to cover a little bit about stress and trauma and why we're talking about those two things together, how they differ. But I did want to note just up front that, as many of you probably know, those two words are pretty common in today's vocabulary, and they might not always be used in the same way that we are using them in this training today. So we're going to cover some technical definitions of stress and trauma and talk to you a little bit about what those mean, but also keep in mind that the language that young people might use, the language that the populations you serve might use, the ways that people may think about either stress or trauma might inform some of the strategies that you select to offer supports and resources. So just a quick breakdown. Sometimes stress is equated with trauma in ways that aren't 100% accurate, but they're definitely related. So one way to think about stress in just a functional sense is whenever an individual experiences demands in their life that outweigh or that are greater than the resources that they may have to respond to those demands, whether those are internal resources, things like resilience, awareness of coping skills, or external resources like social support. Stress includes both a mental and a physical response. Stress can be positive or negative. We tend to think about stress in negative terms. And that's, I think, how a lot of young people in particular talk about stress. But we also want to remember that stress can also include things like excitement or anticipation of a positive experience. The physiological impact can be very similar. Stress is subjective, but there are some ways that you can measure it. You could take a look at hormone levels in somebody's system, and that will give you a little bit more of an objective measure, but the experience of it is still very subjective. Stress is also an immediate response to some type of stimuli that we'll talk a little bit more about as we go through these slides, and stress may not always become traumatic. When you look at the research around stress responses in both humans and animals, what you see is that most individuals who experience stress don't actually end up meeting the clinical criteria for trauma or displaying traumatic symptoms, which tells us that resilience tends to be the norm, whereas trauma tends to be more of an outlier in terms of how people respond to stress. And that's important, and we'll talk a little bit about it as we go through the ACE study slides a little bit later, but kind of keep that in mind for now, because that is a critical piece that is sometimes missed in the discussion about trauma and stress, because of the way that we talk about these things in daily life. As far as trauma, we often think about trauma as having these three components, the three E's. There's an event or stimuli that triggers this experience for a person, and then that experience, the way that an individual interprets it, produces an effect. The effect may be long-lasting or it may be acute. With trauma, the experience and the effects are generally negative. However, like stress, that experience is very subjective still. And that's another key component to think about as we're going through this. And we'll talk a little bit more about why that is as we go through. Not everybody's going to have the same response, even if they experience the same stimuli. There's a range of factors that we'll explore as we go through the ACE information a bit later that are thought of as protective factors. So they contribute to someone's ability to respond with resilience to that experience. Trauma can be also immediate, as is the case with stress, or it can be delayed, or it can be both. Someone might have some initial traumatic symptoms that might be clinical in nature or might be subclinical immediately following an experience. But then later on down the line, they may have some new symptoms, or those symptoms may become worse over time. Or it could be a combination of that. Everyone responds a little bit differently, and not everyone's going to respond to the same thing in the same way or with the same level of intensity. And then the last piece there, while stress may not always become traumatic, trauma always involves some type of experience of stress, some exposure to a stressor. So stress, the way it affects the body, we're not going to get into some of the physiological details. It's not really within the scope of this training today, but some key features that you do need to be aware of is that stress is a normal experience. Everyone experiences stress, and stress can actually be adaptive. It helps us respond to the demands that our environment and our experiences place upon us. There are health effects, however, that can be cumulative when someone is exposed to high levels of stress, to prolonged experience of stress, or to stress in the absence of those resilience building protective factors that I shared about earlier. Stressors may not always be apparent because sometimes they either may be a result of a complicated mix of factors, or they could actually be internal. Somebody can experience stress in response to what they're thinking or what they're feeling. There's always that interpretive component to stress. And that in general, the natural response to stress is to eventually return to a regulated state. So when we're seeing something like trauma, what's happening is something is getting in the way of that person returning to that regulated baseline state. But if you look at that diagram, there's a bit of a stage to this. The first is some type of exposure to the stressor. And actually, I would say within that little blue arrow there between exposure and hormones, there's some interpretation that happens within an individual's mind and emotions that informs them about how they might need to respond to that stressor. Based on that interpretation, there are hormones that are released in the body that prepare the body to respond to that situation. And those hormones tend to contribute to what we used to think of as like the fight or flight response, although now we think of it as more of the fight, flight, or freeze response, because an individual may respond in some version of those three states. And then afterwards, depending on the situation, once that stressor passes, those hormones are metabolized out of the body. They trigger some physiological changes that tend to return the body to a baseline regulated state, and the person no longer feels stressed. In terms of trauma, as we talked about earlier, there are those 3 E's. So the effects of exposure to a stressful event persist over time. They lower the threshold for a follow-up stress response. So those who are actually experiencing trauma tend to be more susceptible to negative events in their future. They tend to have a stronger response to them. They might even perceive something as potentially more stressful following the experience of trauma than they would have otherwise. They also have some difficulty regulating their emotions. They have a difficulty returning to that baseline homeostasis state. And it can have a range of negative effects on health and well-being. One thing to kind of keep in mind as we're engaging communities about trauma and stress is that there may be some differences in how people perceive their experiences and how people respond to their experiences based on demographics. Anything from age to cultural background might affect how somebody interprets an experience or how someone responds to that experience. It also might affect what resources someone has to apply to that response. Those protective factors that we talked about earlier are really critical in determining like how a person responds to stress or trauma and whether or not that's going to have the same type of lasting health effect. When we think about traumatic response, we see a few different categories of responses from individuals. And for those of you whose work may touch on diagnosis or who may have some interaction with mental health diagnosis in your work, you might notice that those follow the DSM-5 criteria for PTSD pretty closely, but there are these 4 categories. So an individual might re-experience their exposure to trauma in some way. That could be through something that is clinical in nature, like a flashback or a nightmare. It could also be having a stronger response to something than they might otherwise have based on that previous exposure to something that was traumatic. And again, that response can be triggered by both an external experience or an internal experience. And so that's really important, is that when you're interacting with people who may have some exposure to trauma, you may not always see all the different factors that are contributing to their experience. And so it's really important to be able to develop that level of trust and engagement so you can actually get that information directly from the individual so they feel comfortable sharing about that experience, so you can better understand what you're saying and better advise on a response that might be more effective for them. Then we have avoidance, and this would be experiences that could be, again, clinical in nature, things like dissociation, emotional numbing, where someone's feelings might not experience the same intensity as they would otherwise. They might also just attempt to avoid experiencing or talking about or thinking about those triggers as a way to avoid the stress response that we talked about, that traumatic response and the distress that comes along with that. That's actually going to be really key, particularly if you're engaging young people who may not have the sophisticated thinking and skills to really process that experience very well. They may not have the comfort with talking about their experiences or without thinking about their experience as trauma. They may withhold it for a number of reasons, particularly when there are peers around. That's something that I found in my work previously as a trauma therapist, was that there is, again, that pressure when you're around a peer group, particularly with young people, to present a certain way. So often what I would see is young people actually just kind of avoiding that experience or avoiding anything that they perceived as a possible trigger for that experience. Then we have hyperarousal. So this would be things like hypervigilance, meaning somebody is kind of on the lookout for a threat and their body is responding physiologically in accordance with that. They may experience or display some irritability or anger. They may have trouble concentrating. They may be kind of always on the lookout for that next potentially dangerous or risky experience as a function of the trauma that they experienced previously. And then that last category there, negative change in mood and or cognition, that could be things like actual depression or other mental health symptoms, but it could also be things like guilt. We talk about survivor's guilt sometimes for individuals who experience a trauma in kind of a group setting or who share trauma with others. Sometimes people feel guilty or bad that they are alive when others might not have survived, or that their experience might not have been as bad as someone else's experience. There are also some distorted perceptions or expectations that come along with that. There can be a lot of self-blame. There can be a lot of kind of changes in how someone interprets events leading up to a trauma. Often people who experience trauma tend to consider some of those experiences that come up beforehand, and sometimes kind of misinterpret those things. They tend to place a lot of responsibility on themselves or maybe on others, and that can interfere with their ability to effectively process those feelings. And then they could also experience some just difficulty experiencing pleasure, which is also a clinical symptom called anhedonia. I see a question there in the chat. Is it Carrie? Are these categories cyclical? Can you share more about that question, please?
It's Carrie, you had it right.
Carrie, hi.
So I was thinking kind of like the stages of grief and how it can be cyclical or you can bounce around. Might one of our clients bounce around between these, or do they tend to cycle through these stages, or just more like if you've had a traumatic experience, you may fall into one of these categories?
No, that's a great question. So when you're thinking about like a formal diagnosis for PTSD, individuals have to display or experience a certain number of these in order to meet that clinical threshold. But for most people, it can be a really complicated mix that's very individualized. So someone might experience of those experiences or responses that fall under that re-experiencing category and the hyperarousal category at the same time, but maybe they're not displaying or talking about experiencing any of those avoidance symptoms or responses. So it can be very complicated. It can change over time. Not everyone's going to display the same things. It's just good to kind of understand that these 4 categories of possible responses may occur either immediately following an experience or even well down the line. And again, it could change over time. Someone might experience one at one time, someone might experience something different later on down the line. I would also kind of point out that for some of these, if they're connected with care for mental health or for psychiatric care, they may actually access some type of like pharmaceutical treatment that actually like manages one part of that experience. So their overall presentation may seem very different as they go through treatment even. Does that answer your question?
Thank you, yeah.
Great, thank you, Carrie. Okay, are there any other questions before we jump into our first breakout group? So what are some things that you've observed in your work that might indicate that some trauma or traumatic response is present? Now, I don't think we'll have time to hear from every group, so I just wanted to share a little bit about what I heard in my group, and it sounded like there was definitely some observation of this for most of the people on the call, and what I heard was that the hyperarousal component was what a lot of people were seeing in their work. And I just thought that was really interesting. Maybe something that I should have pointed out earlier is some of those responses to trauma that we talked about in those 4 categories, some of them are going to be very visible and others are not going to be very visible. So it's also really important to try to think critically and try to assess how people are engaging and what they're sharing for some of those responses that might not be so visible and might not be shared with you up front. Just because someone is experiencing, or sorry, not experiencing any of that hyperarousal presentation, there's no agitation, no irritability, no anger, doesn't necessarily mean that might not be going on there. It also, another good point to consider is that a lot of the traumatic responses in those categories overlap with other types of like mental health needs and also everyone's daily experience. Somebody could absolutely be irritable or angry because of something that they experienced prior to that meeting with you, that doesn't necessarily indicate that there's some trauma happening. So kind of on both ends of that spectrum, be aware that there are things that you may not be able to see immediately, and be aware that the things that you might see might not actually indicate some trauma. So it is very complicated. And that's one of the reasons why we do trauma-informed care, because it really gives you that framework that you need in order to develop that rapport and relationship with the individual, so you can actually hear what their experience is directly from them. Any final comments before we move on to the next session? Okay, we mentioned earlier the ACE study, and this was kind of a really big study that was a partnership between the CDC and a healthcare organization called Kaiser Permanente. You may have heard of them. And what it was a survey of consumers accessing primary care. So people just going to kind of regular doctor's visits, checkups, annual physicals, things like that. The original study surveyed over 17,000 individuals in this practice. And what they were looking at was what the correlation was between early childhood experiences and long-term health outcomes. And what they found was pretty striking and kind of new information, or a new way of thinking about some of these experiences that are traumatic to a degree, but might not seem to be that kind of what we call like the big T trauma, like a traumatic event that most people would see as like traumatic and likely to contribute to trauma symptoms. What they found was that a lot of littler, seemingly mundane experiences, very common experiences, could actually add up over time and correlate with poorer health outcomes on a range of measures. The other thing that they found with this study was that these ACEs were very common. So by ACEs, we're talking about the childhood experiences themselves. When you actually look at the study, they actually like tallied the number of these adverse childhood experiences and assigned individuals a score based on the number that they endorsed through that study. But the types of experiences that they were looking at were really common. It was things like, does this person have a divorce in the family? Does this person have parents who are home? And does this person, have access to adequate housing? Does this person have access to adequate food? Does this person experience some level of abuse or neglect at some point? So sometimes they were really common things. Sometimes they were the things that we would maybe more traditionally think of as traumatic. They also found that as the number of those adverse childhood experiences increased, health outcomes declined. So there was a pretty clear correlation. The more ACEs you experience, the greater your likelihood of having some type of negative health outcome. They found that social and economic conditions resulted in more ACEs, which is probably not surprising to anyone who's ever worked with populations affected by various social and economic needs. They also found that for every adverse childhood experience an individual had, it increased the probability of them endorsing other ACEs. So these experiences tended to cluster. When someone experienced one, they were more likely to experience more, which again, like exacerbates health outcomes in the long term. Here are also the prevalence of ACEs by category that the original study used. So these were some of the things that they were actually asking people about, whether or not they'd had these experiences. And follow-up studies tended to expand on this and include some factors that might be more community level or population level. But these were some of the initial things. So I'm going to ask everyone to just kind of read over these, give you a few seconds, because I think it's really important as you're thinking about it, and maybe think about how many of these you may have experienced, because some of these are very common or broad enough that most of us have had some type of exposure to them. Particularly in this household challenges column, some of the things that they were looking at were things that were not necessarily perceived as likely to contribute to these negative health outcomes in the long run until this study. So that's one of the reasons it was very important. The other categories of use and neglect, I think most of us, even prior to this study, would have some sort of like understanding that those brought with them the potential for some type of traumatic response. But as you're kind of going through this, think about the experiences, just daily life experiences you hear from individuals you may work with or you may serve. Think about whether or not those fall into some of these big categories like abuse or neglect, or whether or not some of these like daily challenges might actually rise to the level of an adverse childhood experience. The other thing that we saw with the ACE study was this pyramid, and you'll see it reproduced if you ever look into any of the ACE literature, but let me see if I can move this out of the way. This is sort of how those adverse childhood experiences are believed to result in the health outcome. So kind of at that foundational level, and I'm talking about that kind of fuchsia colored line down here, because the original study kind of didn't look at the social conditions and the historical trauma as much. That's maybe a newer add-on to some of the follow-up studies. But the idea was that when people were young, when they were children, they would have these adverse experiences that would actually interfere with their neurodevelopment. So these days we know that the brain continues developing to the age of about like 20, 25, 26 or so. And we know that any experiences prior to that time have some potential to actually change neurodevelopment. And that neurodevelopment change can actually lead to those social, emotional, and cognitive impairments or differences that then might manifest as riskier behaviors in a number of ways. So say, for instance, someone might experience abuse or like a disruption in an attachment that was very important to them as a child that might affect their neurodevelopment, which then may manifest as some type of, excuse me, emotional or behavioral need. And then that emotional or behavioral need could contribute to riskier behaviors as they advance through school. Maybe they're not getting the type of support that is actually helping them be successful in school, so they drop out of school entirely. And maybe once they drop out of school, then they have more exposure to other types of like risks in the community. Maybe they start using substances to manage some of their feelings, or because that's a way that they can make money after they've dropped out of school. And then those risky behaviors then lead to some actual significant diseases, potential for disability, other social problems, things like interaction with the justice system, things like housing insecurity, food insecurity, unemployment, and all of those factors that kind of build up through that pyramid over time then lead to potential for an earlier death, so a shorter lifespan for people. And it's really important that that triangle or that pyramid is shaped the way it is. At the bottom, you have all of these cumulative experiences that narrow that experience over time and result in something pretty specific and measurable. I do want to touch base on those bottom two tiers, though, even though they weren't necessarily the focus of that original study, because this is something that is, I think, very much in the the realm of public awareness these days, particularly for those in like healthcare or social service settings. The understanding that there's a variety of historical factors and experiences that disproportionately affect or disadvantage one group over another, and that those historical factors have resulted in the types of social conditions or structural barriers, systemic barriers, that then actually contribute to more adverse childhood experiences. Things like limits on the ability to access a loan to buy a house might then result in a family living in suboptimal conditions, maybe an apartment that's too small for them, or maybe there's issues with a landlord, or it's harder to pay rent. They don't have that time to or that opportunity to accumulate wealth over generations. And so their children then experience the effects of these historical factors or these disparities that continue to manifest in today's world. So when we're talking specifically about HIV and substance use, I walked you through kind of one hypothetical of how that pyramid might actually play out in real life. The reason we talk about substance use and HIV together and that intersection between the two is because they actually do feed into one another. So as we talked about, those adverse childhood experiences eventually can contribute to greater participation in risky behaviors that could either be risky sexual behaviors or substance use. And the experience of one actually creates opportunities to experience the type of events that might lead to the other. And it is cyclical like that. So individuals who engage in substance use might be more likely to engage in some type of sex work or to engage in other types of risky behavior because of the specific effects of that substance. Or maybe they had some involvement with the justice system, particularly in time periods where any engagement in substance use was generally frowned upon by society. I think that attitudes are changing a little bit, but you're still seeing the effects of mass incarceration, particularly of people of color or other marginalized groups as a result of those laws that tend to place a lot of moral judgment on the person using the substances rather than try to understand the context within which that behavior occurred. And then that justice involvement could interfere with other types of opportunities that a person might need to actually turn that around. So it might make it harder to get to school. It might make it harder to find a job that pays well. It might make it hard to find housing sometimes. And so then you get other types of participation in other risky behaviors that could potentially raise the risk of HIV. You're also exposed to more opportunity for violence and victimization if you have one or the other. And that may actually lead to some other needs. Kind of on the flip side, you have HIV, which can create a range of emotional experiences that might contribute to someone's use of substances to self-medicate, or maybe it makes it harder to find housing. So now they have to settle for some housing situation that isn't really good for them, that makes it more difficult to manage their health or to make less risky decisions or engage in less risky behaviors. Maybe it exposes them to violence in some way. That could be things like community violence because someone is not in a safe situation. Which could then contribute to greater substance use. So it's very important to understand that whether you're in an HIV related field or whether you're in a substance use related field, it's really to your benefit and the benefit of the populations that you serve that you're thinking about those things as related, because there is a lot of potential for overlap there, and there is a lot of potential for more effective intervention if you factor in both of those. Okay. The next sections, we're going to go ahead and go over some of the trauma-informed care principles and talk a little bit about how they actually might apply in real-world situations. Just to give you kind of a high-level definition, trauma-informed care is simply just the awareness of how individuals and communities are affected by violence, victimization, and inequity, and making an active, intentional decision to tailor your engagement strategies to accommodate any needs or vulnerabilities that result from that. So my guess is actually reading through that definition is that most of us are doing this to some degree. Most of us have some awareness that the populations that we serve or work with have some unique needs or vulnerabilities and try to address those things. What trauma-informed care really helps with is being able to do it in a systematic, reliable way, and being able to take a step back and look at how the structure of your work or the services that you provide actually might make it harder to do that, or maybe even make it easier to do that. But the idea is that it's not just an individual strategy that one provider can implement. There is really a need to take a big picture look at the environment in which those services are occurring and the systems that are affecting those services if you really want to be as trauma informed as possible. So trauma-informed care has these 6 principles, and we'll go over each one individually, but they are collaboration, empowerment, voice and choice, trust and transparency, peer support, cultural, historical, and gender considerations, and then safety. The first one here, and this is a big one for anyone who, particularly for those individuals who are actually displaying clinical trauma symptoms, but even for those who might be displaying or describing some experience of like a subclinical traumatic response. Remember, I mentioned earlier that that stress response cycle always ends with some return to like a baseline regulated state. But for those who experience trauma, there's a lot of dysregulation. That person, their body is chemically telling them that they are still not safe in that moment, that there's still a threat that they need to respond to. And that's one of the challenges that individuals who experience trauma face, is that even when there is no objective threat to their safety, they may feel like that, they may perceive that. So it's really important for us as providers to really prioritize safety as much as possible. And that's not just the things that we think of as safety. It's really important to engage that person on an ongoing basis about those feelings of safety, so they can continue coming to the services, so they can share openly with you, but also so we don't exacerbate some of those symptoms that are already there. This could be anything from physical or emotional safety to even like the safety of the environment as well. So also be mindful of the spaces in which you're engaging people. Sometimes that's something that you may not have a lot of control over. And if you get creative, there may be some small things that you can do. It's really important to really start off conversations around safety at the very beginning of an interaction or a meeting, so that person, one, knows that that matters to you, but also though you can address any issues in the moment that need to happen. So say, for instance, when I worked as a therapist, we had a fairly small facility, and so offices that we had therapy sessions in were pretty small, tended to not have windows. Sometimes the temperature wasn't very comfortable in them, and it made it very hard for the young people that I served to like really engage effectively in those environments. And I couldn't really do much about the building, but what I could do was maybe take them somewhere else. If there was an outdoor space and the weather permitted, that sometimes was more comfortable for people. We were fortunate enough, we had access to some shared spaces that were maybe a little more comfortable for young people. Sometimes you can alter an environment with things like music or a fan, something that provides a little bit of noise, or providing the participant with some type of object or device that helps them sort of self-soothe in the moment. This piece right here is going to be very critical for building the type of rapport and relationship you need to really get the information that you require to understand someone's needs around trauma. So as I mentioned, just some practical strategies. Start out with the environment, the space. Are there other people around? Does the person feel like they're able to have a private conversation with you? What's the volume like in the environment? Are you able to hear the individual you're working with? Are they able to hear you? Also think about those sort of like nonverbal cues that we all use in our interactions with others. Things like word choice, gestures, facial expressions. People who've had some exposure to traumatic experiences tend to be really hyper aware of those nonverbal cues. And also there's potential for misinterpreting or magnifying the meaning behind something. So it is really important to, again, engage that person in some type of ongoing dialogue about their experience of you as a provider as well, and really make use of that feedback as much as possible. At the very least, like, acknowledge it. I've definitely had individuals that I worked with who felt uncomfortable because of my gender or because of my ethnic background, and there wasn't really much I could do there, but we could talk about it, and that helped facilitate trust in that moment. The last piece there, it's really critical with those who've experienced some type of traumatic event to give them as much power over the situation as possible. And when you're talking about things like safety, think back to that avoidance category of traumatic response. People don't necessarily want to share about things that were traumatic because then it triggers some of that dysregulation and that discomfort. So it's always a good strategy to give someone information up front about like what you're going to talk about and ask their permission to ask those questions that might be uncomfortable for them. Also remember that traumatic responses are very subjective. So validate any feelings, try to avoid any type of like arguing or correction with people. It's very important for someone to feel like they can say whatever they want to say and feel like someone is hearing them in order for them to feel safe in that interaction. Collaboration is all about challenging that kind of quote unquote traditional power dynamic between a provider and a client. It really stems from kind of historical views of like the medical model of services where the provider or doctor is like the expert and the client is there to be told what to do differently or told what's wrong with them. And that really doesn't play out well with someone who's experienced trauma because by virtue of their experiences and their response, like they need to be empowered to share their experiences and to feel like they have some control over that. So it's really important to approach those interactions from a perspective of trying to develop collaboration. You're not there to provide a service necessarily, you're there to work with someone towards their self-identified goals. And there are a lot of different ways you could reframe that power dynamic. It could be anything as simple as just acknowledging that that dynamic was present and talking a little bit about what the past type of dynamic might have looked like and how you could do things differently. It could be being open to and asking for feedback about your performance in that interaction. Really affirm their control whenever possible, and sometimes even directly, like, you know, you're in charge of this session, you get to decide what we talk about. They might seem really simple, but those can be very powerful expressions for an individual who might not really feel comfortable being there at all. It could also be things like, what clothing are you wearing? Because we think of all of those things as like trappings of success or trappings of professionalism, like a doctor in a white lab coat can tell someone something very different than somebody sitting in a chair that's at the same height wearing kind of casual day-to-day clothing. It really gives you some opportunity to adjust how you reestablish that equity in that relationship. It doesn't just have to be giving them that kind of direct control over things. There are these kind of like nonverbal signs or indicators that this is an equal relationship. Again, language, word choice, avoid directive statements, don't tell people what to do, use we language whenever, because it really highlights that you're a team on that. Continue to affirm autonomy. And then, as I mentioned earlier, like continue to ask for feedback. People may still feel uncomfortable giving you direct feedback until they get to know you better, until you have some level of rapport in place. But it's important for that to be a built-in component of that dynamic. So when they are more comfortable, they know that they can share that information. It's also really important in that moment, if you're not able to respond to their feedback, if you're not able to do what they request, talk about that and acknowledge it, and don't just kind of sweep that under the rug. I think most people do understand that we're all humans and we all have our limits, and particularly in like a provider role, there may be limits on what you could adjust. And it's important to be able to acknowledge that and kind of provide some context for the individual so they don't feel like you're just dismissing their input. Empowerment, voice, and choice. Again, we talked a little bit about this with some of the other two, but it's all about returning control to the client. Most organizations these days do some level of kind of client-centered treatment planning in most types of healthcare or social service settings. And that's a really good mechanism to put in place to challenge some of that historical structural barrier that existed in the past with healthcare services. And it's just a starting point. I know when I worked as a therapist, there was a client-centered treatment plan and like a structured intervention that we would use to develop those care plan goals. And there were still some like requirements about what that looked like, what I had to put as a provider based on like managed care needs or billing needs. So really don't just say, well, we have this client-centered treatment planning, like that's all that we need because like they're dictating things, because that's not really like a functional equivalent there. It's always important to kind of continue to ask them to lead that interaction or the services that they're asking. And it really helps avoid re-traumatizing individuals, because one of the things that is fairly common across all individuals who've experienced some type of trauma is that experience takes away some of their control, whether that is actual abuse of some kind where they like literally had someone controlling them, or something that felt out of their control because they couldn't do anything about it, like the loss of a loved one. Like sometimes people feel very powerless, like watching a loved one pass away, because there's not much that they can do. So that ability to return control to somebody who's had some type of traumatic experience is very powerful. Let's see, we talked a little bit about the control, but definitely also reflect any discomfort that you observe in that interaction. Sometimes that can be a way of getting at some of that power dynamic that you're not able to see or that they're not sharing about directly. It can also help you understand like their feelings of safety in that situation, to really kind of share that observation and see if they'll be able to talk about it. It's always really helpful to normalize experiences, whatever they may be, because they are very subjective and they differ very widely one person to another. So really normalize and validate whatever the person is sharing or whatever they're describing to. Definitely also set some conditions around those interactions, ask permission, set some boundaries. When someone feels like a situation is reliable or predictable, they feel like they have more control over it. When someone doesn't know what to expect, it tends to add to their feeling that they don't have control in that situation, and then kind of complicates that ability of a provider to really maintain a safe and trusting relationship. Trust and transparency, for similar reasons that we talked about, it establishes comfort in a relationship. It supports informed decision-making on the part of the client. It's one of the ways that you can provide control. It's very hard to have control or make a good decision or an effective decision when you don't really know what the outcomes might be. So it's also really important to prepare someone in advance, particularly around those situations where you might have to actually exert some control. I know anytime I had to maybe write a petition to connect someone to some type of inpatient psychiatric treatment, I would always make a point of like talking to people in advance about the things that I might have to do in response to certain things that I would see or hear in that session or in our interactions together, and really kind of talk to them about what those outcomes might be, talk to them about some of the reasons why I might have to respond a certain way. And then once you get to that point where you do have to act and maybe exert some control in that situation, continue talking about why you're doing it and what's going to happen, and do as much as possible to offer them some level of control over that. If you're ever in a position where you have to involuntarily hospitalize someone, if there's anything that you can do in that situation to give them more control or to help them like make a choice, even if it's just like something as simple as like what they would like to drink while they're waiting for an ambulance to arrive or something like that. Any little piece like that can help, particularly in those situations where you actually do have to exert control. The other piece that I haven't spoken about here is the privacy piece. It's not just control over themselves. People like control over their experience and who gets to know about it, who gets to know their information, and being able to maintain that privacy and discussing confidentiality and any limits you may have on confidentiality in your work with an individual is going to be really powerful for them to develop and maintain trust with you and to know that you're a reliable person that they can count on. Whenever possible, obviously offer any space or a room or facility that allows for that type of private engagement. And if you're not able to do that, sometimes it's good to have a good, like a conversation up front with someone about, if we're ever in a situation where I can't keep everything totally private, how would you like me to respond to that? Yes, the slides will be shared. I know they were attached to the original invitation. Ezra, if you can advise on any additional steps participants can take to access the slides, that would be great. Oh, that last piece, they're acting with integrity. Trust is not just about giving people upfront information. It's also about showing them that you are going to do what you say you're going to do. So keeping commitments, arriving on time, doing things the same way every time, as much as you can do to establish a routine and predictability in those interactions, you're going to really support that potential for trust and transparency. Thank you, Ezra. I appreciate that. Okay, the next one is peer support. And I think this is one of the ones that can be harder in some settings to provide. But the idea is that when you are trying to talk about a difficult experience, it can help to know that you're talking to someone who's had a similar experience. Sometimes people have had a lot of invalidating experiences when they share about trauma or when they share about a bad experience. And now they don't want to talk about it with anyone else because it's risky for them. It raises the potential of pain. It kind of preys on their vulnerability to some degree. However, when you're interacting with a peer in whatever setting, you know that there's no hidden agenda, you know that it's more of an equitable relationship. There's also opportunities to learn coping strategies that you might not be able to otherwise access, along with the credibility from someone who's actually successfully used those coping strategies. So whenever possible, and again, like I know in a lot of roles, this may not really fall within the scope of your work, but if there are opportunities to facilitate connections, whether that is engaging them about their support network and practicing ways to recruit support through their social contacts, that would be helpful. If there are additional external resources that they could access that might provide opportunities to connect with peers who've had similar experiences, that can also be very powerful. It's also really important to talk about, particularly as you're working towards like terminating a person from a service or making a referral for follow-up, talk to them about ways that they can engage their social support network to support them in continuing to make progress towards that treatment goal. And if there are any, if there's any information shared about relationships that might actually interfere with that process, it can be helpful to have like a proactive plan for dealing with that. Particularly around substance use, I hear that a lot in work around substance use needs with individuals, is that it's easier to manage avoidance of substance use or prevention of substance use in isolation. It's a lot harder to do that when you're actually like thrown back out to the real world and have exposure to friends, family who might continue to be using. Because it's not just the substance itself that's around, you're actually having to navigate the changes in that relationship as well. Sometimes down there at the bottom, having some level of appropriate and intentional self-disclosure can allow you to temporarily, in a limited way, step into that peer role. And that's going to probably vary depending on what setting you're working in. It might vary depending on organizational policies or the types of content that you're discussing with an individual. So really, it's important to kind of check with supervisors and coworkers for guidance on what that looks like. But it can be really effective sometimes if the provider has some type of shared experience that can be disclosed, again, in an intentional, clinically sound way with that individual to offer that peer support in the absence of other opportunities. And the last piece, we touch a little bit on this with the ACE study, but all of those cultural, historical, and gender considerations that might impact someone's comfort in an interaction, that might impact their motivation to access services. It's very important if you're going to be applying trauma-informed principles to be able to acknowledge that directly and challenge whatever power dynamics or barriers arise from that. It can also be really powerful in terms of just understanding really practical things that you can do differently to help make that experience more comfortable, help make that experience safer for the participant. Also, as a provider, particularly if you're in a setting where you're going to be interacting with a variety of people or a diverse population, I think most of us have some awareness that we're never going to be experts on every cultural factor, every historical factor. So being able to just engage a client or a patient directly about those things really helps broaden your understanding as a provider and gives you more perspective on all the different contextual factors that might play into someone's experience of trauma or their comfort and motivation with accessing services after the fact. It's very important to understand at least the basics about like the history of oppression in this country and any like situation or location that you're working in, with the caveat in mind that, again, it's very hard, if not impossible, to be an expert on everything. And it's much more effective to approach these interactions and these conversations from a perspective of curiosity and try to learn what that individual's experience actually has been. You don't want to fall in that trap of thinking that you already know something and assuming that you have the answer to begin with, because that can actually be very damaging for a client or an individual. Maintain that openness to feedback, acknowledge the power dynamic. This can be one of those recurring points of conversation, particularly if someone identifies some type of cultural, historical, or gender issue in that interaction with you. Being able to continually talk about it and continually apply that individual's feedback can really help address some of that discomfort. The question about virtual therapy, do you mean for the cultural, historical, and gender considerations? I didn't see when that question popped up in the chat. I apologize.
No, sorry. My question was just when you were going through the main kind of parts of trauma-informed therapy and establishing safety and kind of being able to engage somebody. I've just been having difficulties doing that virtually, especially establishing like that safety and making sure that individuals are in a safe place. I see a lot of patients with DV trauma. So that's what kind of
Sure, yeah, it can be difficult depending on how you are implementing virtual services, but I think the big one that comes to mind is privacy. Being able to have an upfront conversation with someone, being able to get some information from them about the setting in which they are accessing those services, and coming up with a plan on ways to protect privacy as much as possible. It can be a lot easier for them to engage if they have a safer space. I think also, and again, technology is something that we're all getting more used to with the pandemic, but knowing the platforms that you're using and being able to plan accordingly to make sure that you are on the call when you need to be on the call and that the person has access to whatever time they expect to have. Sometimes that may also involve like setting some boundaries up front, because I think sometimes with a virtual interaction, it can be both easier and harder to reach a provider. So if there are any limits on how easy it is or when you can be reached, that can be a good thing to discuss up front. I think sometimes that peer support component may come into it too. Depending again on the setting or the type of interaction, there may be someone there who can assist with at least setting up the call, and you want to make sure that if someone has that support or wants that support, that they have access to it. I've definitely had virtual interactions with other providers since the pandemic where, you know, you might spend 15 minutes while someone is getting flustered because they can't access like the Zoom link or something like that. So just really making sure that someone feels comfortable with whatever setup you have going into it, and that they have the opportunity to kind of share some feedback on the way and make additional requests that you may be able to acknowledge that would be helpful.
Awesome, thank you.
I do want to be respectful of time. It looks like we're running a little bit long. I'm actually going to, if it's all right with everyone, jump the next discussion question so we can get through to the care continuum. And then hopefully at the very end, we should have maybe a few minutes to talk a little bit about any follow-up questions. But what the HIV continuum of care is essentially a framework for treatment and prevention and identification of supports or intervention strategies that might help someone manage, particularly HIV in this case. There are two types of continuum that the CDC monitors. One is the prevalence continuum, meaning it includes statistics that focus on all people who have HIV, and that includes both undiagnosed and diagnosed. So there's a projection component. That number is going to be higher than the diagnosis continuum, just by virtue of the fact that it includes an estimate of those who are undiagnosed. Then there's the diagnosis continuum, which only focuses on those who have actually had a confirmed HIV diagnosis. And the reason I point this out is because sometimes when we're focusing on specific populations, it may be statistically preferable to focus on either the diagnosis or the prevalence continuum. It may also be good to keep in mind as you're looking through statistics about HIV infections and people living with HIV that sometimes the numbers may seem different than what you've seen in another source. And that may be one of those reasons. So just kind of keep in mind, it's not a critical component to the work that we're going over today, but just kind of keep in mind that the CDC actually uses kind of two different approaches to measuring people's movement along that continuum. And this is the continuum in a nutshell. So it starts out with those in the diagnosis stage, and we'll go over some definitions of what all of these stages mean in just a moment. But you'll notice a few things. One, you may have heard some of this terminology used differently, and that's okay. Sometimes in lay speech or in less formal settings, people tend to use these words interchangeably sometimes. I've definitely even seen like local governments or health authorities like redefine these terms based on the data that they're collecting or to present the data that they're collecting. But this is kind of the CDC formal version of the continuum that begins with diagnosis, and then there are those receiving care, there are those retained in care, and then there's viral suppression. I do want to point out, and we'll talk a little bit about why here in a moment, but that linkage stage is a component of the whole care continuum. It's separated there in that image in some of the further slides because it uses a different denominator when it's calculated, so it can't be statistically compared to those other stages. So say for instance, well, actually, let me do the diagnoses. The definitions really quickly. So for the diagnosis, CDC defines that as percentage of all the people diagnosed. Receipt of care is percentage of those diagnosed with at least one CD4 or viral load test. Retained is diagnosed with at least 2 CD4 and viral load tests at least 3 months apart. Viral suppression is diagnosed with a viral load under 200 copies per milliliter at last test. And then the last one is diagnosed in the same year, plus 1 CD4 or viral load within 30 days of diagnosis. So I mentioned earlier that linkage is a little different. Linkage numbers always refer to 1 year. So only those diagnosed in that year. All the other stages refer to total. So it includes individuals who were diagnosed in previous years as well. Just talked about that. The reason we focus on linkage is that linkage represents optimal treatment. So if someone is connected to treatment and engaged by healthcare providers soon after a diagnosis, they tend to have better health outcomes in the long term. It can also be harder to re-engage services if somebody waits too long. I know a lot of those of us on the line who have some like linkage responsibilities or our work touches on linkage, you know that you don't get someone engaged right away, sometimes they can disappear, just kind of fall off the radar, and we may never know what happens to them. They may resurface at some point in the future. But in general, if you can catch someone at the point of diagnosis and get them engaged in services, their health outcomes are likely to be better. I would also say, and again, this is kind of true on our project even, we have a linkage component through our partnership with Haymarket Center. We don't really use the word linkage, according to the actual formal CDC definition, which is connection within 30 days. We try to do that. We definitely try to prioritize efforts to get people engaged right after a reactive test. However, we potentially try to link them to follow-up services over the course of a 6-month period if an individual isn't ready or if they don't engage right away. Just some stats that I'm going to run through fairly quickly here. In Chicago, you'll notice that about 20-25% of new HIV diagnoses occur in individuals aged 13 through 24. And that there is a disproportionate number of people of color who are diagnosed relative to white counterparts. So in terms of trauma-informed considerations for diagnosis, it can be helpful at each stage in this process as we're kind of talking about it. Let me actually back up here. For each of these slides, you're going to see some changes in the statistics here. So you're going to see a different percentage of individuals diagnosed relative to linked. One thing I do want to throw out here just before I move on is that, as we mentioned, linkage is calculated differently. So when you see a change in the statistics between the diagnosis and the linkage stage, or between the linkage and the receipt of care stage, it doesn't necessarily indicate that there's a barrier because those numbers are not directly comparable. If you see a difference between, say, the receipt of care and retained in care, or the retained in care and viral suppression stages, that might actually indicate that something is posing a barrier that's affecting the number of people moving through those stages. Linkage is different, though, because it's calculated differently. So just keep that in mind, that one of the points of the continuum is for providers to identify possible barriers in people's movement from one stage of care to the other. And so it's important to compare those statistics as much as possible so we can kind of see, in this location, is there something that is really helping us get a lot of people diagnosed? We're finding a lot of new cases, but something's happening between these stages that's preventing movement to the viral suppression stage. And that's a really good thing because it helps us kind of identify things that we can do differently to help people move from one stage to another. But when you see differences with that linkage stage, it doesn't necessarily indicate that there's a barrier because they're just calculated differently. Let me back up here to diagnosis. I wish we had more time to kind of talk a little about what people see in there, but just something to consider at each stage in this process. With whoever you're working with, it's helpful to consider how their emotional experience may change as they move from one stage to another. So some emotions that I've heard from people kind of in that diagnosis stage or who are newly diagnosed with HIV, oftentimes there may be some guilt, some shame, some fear that even prevents them from getting tested, but also even after they get a reactive test, some of that might persist and might interfere with treatment. There may be some ongoing risky behavior. Sometimes those risky behaviors may be survival strategies for some individuals. If someone is engaged in sex work or has some level of housing insecurity, they may have some need to engage in riskier behavior that someone else who doesn't have those experiences might not have. So it's really important to try to understand the context in which all of this is happening for an individual if you're going to offer the best possible supports to promote movement along that continuum. Just some kind of careful sample strategies based on what we talked about with trauma-informed care. Make sure you're honest about how the test works, what happens after the test, give people some hypotheticals based on what the results might come up, and definitely validate those feelings and thoughts as you're going along. That one, you're going to see that in every single slide to the end of this presentation because I can't stress that enough. whatever stage you're engaging someone in, it's really important for them to know that you're hearing them and that you understand what they're come from and that you're not judging them. So anything that you can do to validate their experience or what they share with you is going to help secure that relationship and promote their continued engagement in services. Linkage stats, you'll notice that there is a little bit of a difference as we go through. Again, keep in mind the numbers aren't like directly comparable, but about 3 out of every 4 individuals tend to go from diagnosis to linkage, meaning that within 30 days of that diagnosis, they start some type of treatment, or at least are like scheduled to start treatment. For linkage, one of the things that makes it really hard for people to connect is that there may be some hopelessness after a diagnosis. There may be some fear, confusion. They might not know what to expect. Sometimes the systems themselves can be really difficult, either with navigating changes from one provider to another for follow-up treatment. Sometimes the insurance might be a little complicated. Even though we know that there are resources out there to pay for treatments, that might not be something that individuals are all aware of. Also keep in mind that getting a diagnosis for HIV might have some traumatic response for individuals. So now you're actually taking someone who may already had some traumatic responses and complicating that further with a new experience. Very important to consider some of the resources and supports that are available, peers who may be able to support, and again, keep validating those feelings and thoughts. I'm going to share these slides, but just in the interest of time, I'm going to go ahead and breeze through some of the last statistic ones and really highlight some of the strategies here. So for receiving or retained in care, these are individuals who access care, gotten their first CD4 viral load test, and maybe are now working on continuing to return to a provider for treatment for medications. Some emotions that might interfere. It can be exhausting to attend appointments. There might be more travel involved. There might be expenses just getting to appointments. There might be some frustration around interactions with people who schedule appointments, or medical or healthcare staff. Even if they like their doctor, they may have some interactions just getting into that appointment that are frustrating for them. It's also important to remember that not all providers out there are going to approach things from a trauma-informed perspective. So they may be actually having some really negative experiences, and it's important for you, if you're a support, to continue talking to them about those experiences and offering what support or advocacy that you can. In the last stage, viral suppression. So these are individuals who have engaged in care to the point where the virus is under control with medications in their system. When someone reaches this stage, consider how the emotions might change. They're maybe not thinking or feeling things that are that negative, because this is actually a fairly successful outcome for them, right? Like, this is where they are managing their health in the best way that they can. They have access to services. They've clearly had a provider that worked for them if they got to that point. So sometimes the emotional interference may actually come from some of those positive emotions. There may be a little more risk taking at this stage. There may be some negative feelings, though. Sometimes people have described to me anyway, some perception or experience of discrimination around their status, or talking to people about their status. So it's not going to be all positive, but definitely keep in mind that once someone reaches this final stage in the continuum, those emotional barriers may be very different than what they were at the beginning of the continuum. I would also kind of keep in mind that usually as people get to this stage, the intensity and the frequency of services tends to decrease. Sometimes they may actually leave a service, or a service may only offer support up to a certain point or up to a connection to treatment. So someone might be experiencing less support at this stage in the continuum than they had at previous stages. And it may be important to kind of check in with someone and see ways that they can develop some of those natural supports in their life to replace the provider support that they were receiving beforehand.
Thank you so much, Mead, for your presentation, and thank you to Connect for Youth. This was a really great presentation, and we've made sure that it's recorded. So we'll follow up with an email with a link to the recording as well as the training slides. Again, the training slides with an outline with notes is linked in the calendar invitation if you'd like to open it in the meantime. Otherwise, be on the lookout for a follow-up email from myself with a link to the recording in a box folder that also has previous trainings that we've hosted, as well as those training slides.